it is a total hip reconstruction. You see that? You see the column screw? There was one hip reconstruction was allowed with an iliopubic screw. And I don't know why, in the middle of all this nice reconstruction, my eye caught the column screw. Just for a reason or another. And when I want to talk about column screws, I always have this funny feeling. Why do we like column screws? Orthopedic surgeons love column screws for a reason or another. They like to look at the reconstruction and they see a column screw. Wow. It is an intraosseous screw which is going inside the bone in an anterior column and posterior column. And they like column screws. They are elegant tools, right? They're very elegant tools. They look nice on X-rays. They go from small portals. They are fancy. They're elegant and fancy tools that we use to fix column fractures. It's a type of that. But anything that's fancy and elegant is not without a price. It can have a high price. So the learning outcomes of our talk today is going to be about the column screws, what they are indicated in. We're going to stress on adequate, perfect, precise visualization if you want to put column screws. And throughout the procedure, I'll keep on telling you, beware of the high price. The high price of putting column screws. Okay. Now, again, I'm going to stress on the fact that column screws are indeed nothing but tools of fixation. Okay? They are just an extra armamentarium to have the aim of our surgical intervention, which is always, always anatomical reduction first, and then into rigid internal fixation. And all the literature from the old times to the recent times have stressed the fact that our aim is not to put a column screw, but to do an anatomical reduction, and perhaps then fix it with whatever way you want to fix it. Now, where did the idea of a column screw come from? Actually, it comes from the concept we've all been taught by the pioneers about how the acetabulum is made between an anterior column and a posterior column. And then, classically, a column screw is basically something that goes along the long axis of the column. So you're sticking the screw all the way along the long axis of the column in order to fix it. Whether you do it along the anterior column or the posterior column. And obviously, you can do that either in an antegrade way or retrograde way, depending on how you're approaching the fracture. And then you can either do it through the same surgical approach, or through a snap incision through the skin, or percutaneous. I don't like to use this word a lot. Okay? So let's try to assess a few cases about different examples of using column screws, how we put them in, what are the portal of entry, and the most important technical issue here that I'll discuss is mostly about the viewing, how we're going to visualize the screws, and how we try to reduce the possible high price. We're going to have another exercise about column screws later on, so we're going to stick to the basics. Now this is basically what we call an associated wall column fracture. Okay, it's a floating acetabulum, and we're going to try to put one of the most commonly used column screws, which is basically the ilioischial screw. The ilioischial screw is a commonly used screw. It is an antegrade posterior column screw, usually being put from an anterior approach. So basically, the CT scan will help you, can identify to you where the fracture is. It can give you an idea about the width of the column, how it is, and where you're going to put your anterior fixation, and then how you're going to reduce it. Now, where does the classic column screw go? The classic column screw goes there. For it to be a truly long axis column screw, you have to really go way proximally and posteriorly to go along the long axis of the screw to reach the ischial tuberosity all the way down. Sometimes you can have variations of that, angle screws, screws which go from one column to the next. They're not classic column screws, they're just transgressing screws from one column to the other column. Okay, so this is basically the portal of entry of our classic posterior column screw. Right? Can you all see that? You all see that. Now, a very important issue about column screws is whether or not you put your column screws into the joint. And that's very, very, very serious. Now, I'm going to stop here to stress on a concept. And the concept is how to be outside the box. Anything that's inside the box will stay inside the box no matter how much you rotate your viewing. And if it's outside the box, there's one specific view where you can actually get your screw outside the box. So if on any view it's outside the box, it is outside the box. If on all views it's inside the box, it is inside the box, and the box here is this joint. So let's have a little look here. Which of these screws can be inside the box? You might be concerned about that screw, or any of these screws. In this view, this is the femoral head, this is the joint. All the other screws are basically outside the box. This is the most inferior screw because this is here, the plate near the sacroiliac joint. And the most distal screw over here is outside the box. So it's outside the box, it's outside the box. The concept I'm trying to get to you is if you put in column screws, checking the column screws by taking different views all around until you're absolutely certain that any screw should be outside. Now that's an important point. Let's have another look and see. What are the different views that we can use? These are the classic views, and then I'm going to show you some other views as well. This is the classic obturator oblique view, and this is the classic iliac oblique view. Now I'm bringing again some of the inlet view as well. When we put column screws, we try to modify our viewing again. So the obturator oblique view is a good view, obviously, but you can actually improve that view by looking down, and I'll show you this later on, to see what is an outlet obturator view. The same applies for iliac oblique view when you combine it with an inlet view. What about another case? This is a T fracture, and the T fracture can be fixed with what we call a short segment fixation using column screws. Again, the rule is reduction, reduction, reduction. You have to obtain an anatomical reduction. Okay? And then you can put your column screws. Where is the column screw? This is the column screw. Here there's one screw here, and there's one screw there. So these are two iliac screws. These are the common antegrade posterior column screws. This is not a very commonly used screw, but just for the sake of going according to the logical sequence, we can put antegrade screws. Sometimes you put retrograde screws. This is not a very common way, but sometimes you do that for this type of fracture. This guy has this type of injury. It's a very low posterior column injury. It's quite gapped. And we thought of fixing it. And for that, we're doing a posterior Cocker-Langebeck approach. And the posterior retrograde screw is going all the way from down here, and it's going up. And then the screw is going all the way from below up. It's an extra stability in addition to using that plate. Can I point your attention to where this guide pin is? It is right next to a very unclean area. Okay. What about anterior column screws? That's the most fancy sort of screw that people like to use. In this particular case, the indication of this was to do an extra fixation for this type of transversal posterior wall fracture. Transversal posterior wall fracture in an elderly lady around the age of 70, but she's an active 70 and she's got marginal infection. So she needs to have some kind of surgery to the posterior wall. And for that, we're going to put the anterior column screw. Sorry. Now these are the viewing I wanted to stress upon. I just showed you the obturator oblique view, and I showed you the iliac view. Now let's have a look here as well. In this particular view, you want to see the anterior column in profile. And the anterior column, not only it is like this, but it is also looking down a little bit. So when you want to see it really in profile, you need to see it from that side, that's an obturator oblique view. You need to see it from below, and that's an outlet view. It's a combined outlet and obturator oblique view. You have to be absolutely careful as you're going with your guide pin to make sure you're not inside the joint, and you don't want to go up because up are the vascular tree. Now the same applies to what you want to see in profile for the anterior column from an iliac view and an iliac view. So we use an obturator outward view and an inlet iliac view. And basically, these are the types of columns you ought to put. Now, the thickness of the screw can be quite variable. There have been lots of research about it. You can go as far as 7 millimeters, 7.5 millimeters sometimes, to fill a good column. But obviously, all these studies, there are variables because anatomical variations exist. So you can use the bigger screw that you can put safely. Another possibility, another indication for using this screw when you have an associated pelvic and acetabular surgery, again following the same principle, you reduce the sacroiliac joint, you fix it, and then perhaps such a fracture can be done in a sort of percutaneous way. Now beware, in this case, the column screw is being used as a reduction tool as well. If it fails to reduce it, you have to reduce your fracture. And for that, that's what we use. We go, this is the outlet, oblique view. This is the iliac inlet view, and you can see in profile your fracture. Then you can go with your guides and you pin, and then as you tighten your screw, you can reduce and fix your fracture as well. Now, another possibility which has particular conditions of application. This is not how I suggest that you do it. This is not particularly for transverse fracture, but this is a guy who was a hepatic patient, was not fit for surgery. He took some swabs in an ICU after his admission and he had MRSA all around. So one option that we chose to do for him was to do a percutaneous fixation. So this is a particularly tailored indication for this type of screw, whereby we put again the column screw, an anterior antegrade column screw, and we go all the way and you can fix, reduce and then fix the fracture. The retrograde anterior column screw has two more frequent indications. I don't use them very frequently. You can use them in a pelvic fracture. If you've got a low sort of pubic radius fracture, you can go from the medial portal just below the pubic tubercle, go retrograde to fix a pelvic fracture. Sometimes, if you've got a column fixation, you can also use this in the retrograde way. Notice your portal of entry is much more lateral in this case than in the case with a more distal anterior column fixation. Some people think it's simpler and it's easier than the classic antegrade anterior column screw. Now it's all now about complications. We have to be absolutely certain that you do not choose a fancy, elegant way of fixation on the expense of price. Beware of any intra-articular metal work. Intra-articular metal work is a blowout of the joint. If you've done perfect anatomical reduction and a piece of metal is inside the joint, that joint is gone. You can't fix it anymore. And for that, I would end up by saying in summary, we have to appreciate what are the column screws. The column screws are nothing but modalities of fixation. They're elegant. They're likely to be quite precise. They can be put within a major tailor of how you're going to reduce and fix. This is an extra tool to use. But always when you think about using a column screw, remember the high price. Thank you very much.
Thank you very much, Professor Fuad, for this nice talk. Any question for Professor Fuad? Abdullah?
Very nice talk. Thank you very much, Shahid. I'd like to ask about if you have a T-type scapular fracture of the posterior wall and you decided to go posterior push because of a posterior dislocation of the head, this is logic, and now we are trying to fix the anterior comb anterior screw. In some cases, you can reduce it very well and you put the screw, and then you feel that you are losing the reduction after a while. In a T-type, not a transverse type. What do you think?
What do you mean by after a while? I mean, after the patient starts to walk?
No. It's 2 weeks.
Or intraoperatively?
Not intraoperatively. You reach the anatomical reduction intraoperatively, and you put your screw, and you are sure that the screw is very good. It is not a transverse fracture.